Very warm welcome to this third instance of our Modeling Perspective speaker series this year. We're covering here, as you know, different topics that are related to public health modeling. And we always like to have a focus on how modeling works together with practical advice and decisions. So it's a real pleasure that today we will have Kaja Abbas here with us. He's an associate professor at the London School of Hygiene and Tropical Medicine and also at the Nagasaki University in Japan. And he just told me that he's actually joining us from Japan today. It's 10 p.m. So thank you so much for staying up for us and with us. We hope to make the best use of your time. Kaja's research focuses on modeling the impact of vaccine programs. And for that, he collaborates very closely with partners in decision advice, decision making. And he's really worked in a variety of different countries and contexts. Today, we will hear him talk about the impact of human papillomavirus vaccine. Very, very interesting topic. And so we will hear Kaja talk for about 25 minutes, and then we look forward to a discussion with our speaker afterwards. So if you've got any questions while he's speaking, please write down so you have them ready afterwards, or put them into our chat that we're looking into as well. Yes, and with that, it's a pleasure to have you here, Kaja. Please share your screen and take it away. Thanks.
That's good. Thanks, Rene, and thanks to all the colleagues for joining today. And you can hear me well?
We can hear you. Yes.
Okay, great. And can you see the screen?
Yeah, we can.
Okay, fantastic. Okay, excellent. So it's a pleasure to meet all of you today. And today I'll be kind of presenting some of the work for the human papillomavirus vaccine impact modeling. And this is a vaccine that has been available for the last almost 20 years now. And it protects against cervical cancer in women. It also protects against some additional cancers like anal, penile, and also head and neck cancers. But the main impact of this vaccine is primarily on cervical cancer in women. And the two high-risk types, the HPV 16 and 18, they account for almost 70% of all cervical cancer burden. And then there are additional high-risk types like 31, 33, 45, 52, 58. They account for almost another 20% of all cervical cancer burden. And we had vaccines against HPV 16 and 18 for the past 20 years, which is the bivalent and quadrivalent vaccine. And the nonavalent vaccine also includes these 5 additional HPV types. So altogether, a nonavalent vaccine can protect against almost 90% of all cervical cancers, while the bivalent and quadrivalent vaccine can protect against almost 70% of all cervical cancers. And that being said, currently still there are more than 660,000 new cases of cervical cancer happening globally, and around 350,000 women die from cervical cancer each year. And when the current Director General Tedros, when he took over WHO Director Generalship, one of the key signature programs that he put together was one of the cervical cancer elimination strategy. And this one, which is kind of led by WHO, looks at 3 different aspects: by improved HPV vaccination rates, also with improved screening rates, and also with improved treatment rates, almost looking at like 90% coverage of HPV vaccination for adolescent girls, and then with around 70% coverage of screening for adult women, and then among 90% of coverage for treatment among women who are diagnosed with cervical cancer. And in this case, we look at the analysis in the context of the HPV vaccination impact. So when we look at the burden of cervical cancer at any given age, and then if those women would have been vaccinated during their adolescent age, then potentially there will be a proportional reduction in the cervical cancer burden in the later ages of life. So the vaccine is given at the adolescent age by 15 years of age, and in some countries between 9 to 14 years based on each of the countries. And across the life course, it provides protection. So anywhere in the future, it will actually protect against getting cervical cancer. And also the vaccine efficacy is much higher if the vaccine is given pre-sexual debut. And with respect to and also proportionally, how much of cervical cancer are caused by the types that are included in the vaccine, and with respect to the coverage, which used to be, when it was originally introduced like around 20 years before, it was a 3-dose vaccine coverage or 3-dose vaccine scheduling, which then moved around 10 years before. For example, in the UK, it moved to 2-dose schedule. And in the recent past, in the last few years, in the UK, they have moved to 1-dose schedule. And this 1-dose schedule is now getting more prominent in many other countries as well. Especially for countries that are now starting to introduce HPV vaccine, many countries are moving to a 1-dose schedule rather than, while there are still countries that actually use a 3-dose schedule. For example, in Japan, for the bivalent vaccine, they still use or the quadrivalent vaccine, they still use a 3-dose schedule, while they use a 2-dose schedule for the non-valent vaccine. So what we mean by proportional reduction is that the larger, so this is the burden, for example, looking at just one cohort. For example, this is the cohort that was born in, say, 2011. So for example, 2020, they'll be 9 years old, they'll be eligible for vaccination. But if they were not vaccinated across their lifetime, for this particular cohort, this would have been the burden of cervical cancer. And then what if this particular cohort could have been vaccinated with a bivalent or quadrivalent vaccine? Then proportionally, based on the coverage, there's going to be a proportional reduction in burden. And then when the non-valent vaccine, its protection is even more higher, because with the non-valent vaccine, it's around 90% impact on protection, while in the bivalent quadrivalent vaccine, it's around 70% reduction in burden. So it's going to be even more further impact across the cohort, for example, the cohort born in 2011. And we can look at the same in other cohorts as well. The next year, the cohort across the life course and so forth. For example, this is the cohort, for example, if they would have been without vaccine, this would have been the impact of cervical cancer or the burden of cervical cancer across the life course. But if they would have been vaccinated, the corresponding reduction. So this is the impact that we see in reduction with a bivalent quadrivalent vaccine, which protects against HPV 16 and 18. And then with respect to the non-valent vaccine, protects against even more 5 risk types. So it's going to be even further reduction impact. And the one that we see on the left-hand side up here is the cases. And the middle one is looking at the impact on deaths. And then the last one here is looking at healthy life years that can be gained by providing HPV vaccine, or basically the inverse is the disability adjusted life years lost by cervical cancer and how much it can be reduced by providing the HPV vaccines. And when you look at the impact that this vaccine could have by regions and by countries, then we start to see differences in the impact. And that is primarily driven by the disease burden pre-vaccination. And it's driven by 2 things. One is relatively because of the differences in risk of cervical cancer, but also with respect to fatality, looking at the with respect to access to quality healthcare as well. So one is the higher risk. Second, access to healthcare. So both of them combined together, primarily what we see is the impact will be much higher for every, say, 1,000 girls that are vaccinated, for example, in the WHO African region, compared to, say, for example, the European region. So in essence, if you want to maximize the impact that we have with a limited number of doses of HPV vaccine, then we potentially would want to prioritize the African region first, and then later on prioritize the European region. But then what has happened in the introduction process is the countries that are actually at much lower risk and the regions that are, relatively speaking, at lower risk, these are the countries that have introduced the vaccines first, like in 2006, 2008, even by 2010, many of these countries have introduced, while many of the low-income settings, which relatively had a much higher burden, were some of the last ones to introduce, and in fact, some of them have not yet introduced the vaccine. So this kind of showcases the large-scale inequities that we had with this vaccine, which is not something that has always been seen with other vaccines in the past as well. So in contrast, when you look at the COVID vaccine introduction, while there was a lot of highlight in media, for example, the inequities, there's also the COVID-19 vaccines, the COVID vaccine rollout was the most equitable distribution that we ever had in history. Almost every other vaccine will have like decades-long difference introduction in a high-income country to a low-resource setting. And the Gavi, the Vaccine Alliance, was formed in 2000 to address some of these inequities in vaccine introduction, uptake, and coverage. And with Gavi coming into place, the gap has reduced to roughly still around 10 years or so. But it used to be around 30 years, like a vaccine before pre-2000, a vaccine that gets introduced in a high-income country to get introduced in a low-income country will take around 30 more years. In regards to efficiency, and this is analysis that was specifically conducted in the context of Gavi-supported countries, and then what we see out here is the global impact that we are able to see, and here specifically focused on the Gavi-supported countries. And here we're looking at, for example, the resources that are spent on HPV vaccination, but correspondingly there will be a reduction in treatment costs because of the reduction in cervical cancer cases. So that gives us the net cost of HPV vaccination program. But what if we had invested those resources in the current health system? So this is looking at the health opportunity cost, like how much will it cost to gain one healthy life year in the current health system without the HPV vaccine program. So by introducing the HPV vaccine program, because we are taking resources from some other program to invest in the HPV vaccine program, but of course there's a gain and reduction in less treatment costs for cervical cancer. So in essence, this will give us how much net gain that we can get from cervical cancer, like by introduction of the HPV vaccine. So how many healthy life years can be gained from the HPV program? And one that we have from the HPV program, but what if those resources would have been spent in the existing health system? This is what we would have gained from the existing health system. So the difference between these two gives us the net health impact. So in other words, this is what we gain from the HPV program, but the same resources, if they would have been spent on the existing health system, this is how many healthy life years would have gained. So thereby the healthy life years that we gain from the HPV program are much more larger compared to what we should invest in, what you could have invested in the current existing health system. So if the net health impact is positive, that indicates the program is cost effective to be added within the current health system. If not, we'll be taking resources from much more efficient programs to actually introduce the HPV vaccine program. And when we look at the market prices among the Gavi-supported prices, Gavi-supported countries, introducing HPV vaccine program will actually turn out to be not cost-effective for most of the Gavi-supported countries. But this is at the private market prices. But for the Gavi negotiated prices, the HPV vaccine program will turn out to be cost-effective for all the Gavi-supported countries. So this kind of addresses the value of Gavi in negotiating prices, wherein it is good value for the resources that are put in each of the health systems for each specific countries as well. But that being said, when you look at the inequities, and this is looking at the countries that have so far introduced HPV vaccines, what we see out here is, for example, the countries at the very top out here, like Tanzania, Gambia, Zimbabwe, these are countries that can gain more impact for a given number of doses. For example, every 1,000 vaccinated girls, we can actually avert around 20 to 30 deaths among these countries. Compared to the countries at the very bottom here, for example, Switzerland and Finland, so forth, for every 1,000 doses that are given, the number of deaths can be averted is relatively speaking lower. But then the way the coverage is almost inverse of it. So the countries that can have the highest coverage so far had very low coverage, while the countries that have, relatively speaking, less impact are the ones which with higher coverage. And we can express these inequities in this form of these concentration curves. And the larger the area under this curve basically showcases large levels of inequities. And this is not only seen at the global level, but we can also see it within each of the regions, including the European region. But also within high-income countries, also we can see a similar impact. So even within high-income countries, we have these levels of inequities that we can kind of see and address. So the model that we used is is simple, like a proportional impact reduction model. It's a static cohort model. So there are no herd effects included in this. And even with that limitation, when we look at the cost effectiveness estimates, it is efficient, it's cost effective for all countries. And if it actually include the indirect effects of vaccination, and also if we include the impact of cross protection, it will be even more cost effective than what we have estimated. And why the vaccine was introduced around 2 decades before, it used to be a 3-dose vaccine. Around decade, some of the countries moved to a 2-dose vaccine schedule. And in the recent past, in the last few years, some of the countries have actually moved to 1 dose. And for many of the countries, actually Gavi is facilitating the introduction of the vaccine this year and so forth. Most of the countries are introducing through the 1-dose schedule. And this analysis was done a few years before, where we didn't have much data on what could be the efficacy for the 1-dose vaccine. So here, some of the assumptions that were used were quite conservative. But what we want to see is that how much impact that we can get from a 1 dose, and how much incremental impact can we get going from 1 dose to a 2 dose. And this is on a log scale out here. That way, what we can see is that the incremental impact, or in the sense, the number of doses we need to get the same level of impact we can get from the first dose is much more higher. So indicating the first dose is highly efficient, and the second dose is relatively inefficient compared to the impact we can get from the first dose. But if the new evidence that is coming in, it's actually even more higher than what we anticipated. So if we introduce the newer data, it will actually turn out to be even more higher. Like in the sense, the first dose impact is almost all the impact that we can get, almost similar to what you can get from a 2-dose vaccine. So, but that's based on the evidence so far. And then, so many of the countries are moving to the 1-dose schedule now. And this is a study conducted in the context of Kenya. And in this case, the health ministry was specifically interested in some of the bivalent and the quadrivalent vaccines, but also with respect to the monovalent vaccine. While the bivalent quadrivalent vaccines are supported through Gavi currently, right now we don't have any monovalent vaccines supported by Gavi. And the pricing unit for the monovalent vaccine in the context of Kenya is still, when you look at the government perspective, it's not cost effective. And when you especially look at the societal perspective, it's just at the verge of cost effectiveness, while this and the bivalent quadrivalent vaccine are much more efficient utilization of the limited resources. And then currently, as things stand, Kenya is moving forward the bivalent quadrivalent vaccine. And then it's likely that the new non-valent vaccine is likely to enter the market by end of this year or early next year, which is likely to be supported by Gavi as well at prices unit, which is likely to be cost effective for many of the low and middle income countries and Gavi supported countries. But it's not at this point right now. Yeah. So this is also for what I've shown as the kind of inequities in settings where we didn't have the resources to provide the vaccine and why the coverage was so low or even practically none. But in the context of Japan, for example, this also seen to a little extent in Ireland and Denmark as well. These are countries that had the resources to provide the vaccine. And in fact, this curve is a little bit missing out here. Actually, Japan had a coverage of almost 70% around 10 years before. And within a few months, the coverage dropped to less than 1%. And then it kind of remained like that for almost close to 9 years at this point. And now it's coming back again to around 30%, 34% right now. And the reason for this is some of the adolescent girls experience side effects, which was basically associated in timing with the vaccine, but it was not proven to have any causal effect mechanism. But by the time they could do the vaccine adverse event reporting analysis and coming up with the conclusion that the risk of the vaccine is not associated with the vaccine, before that, there was a large drop in confidence and vaccine hesitancy in the community, wherein basically a lot of public protests had happened as well. And then basically the coverage dropped to less than, we are looking at like a less than 1%, almost close to 0%. So almost for a decade in Japan, the vaccine was available. Any adolescent girl who wanted to get the vaccine can go to the local clinic and can get the vaccine at no additional cost out of pocket. But still, the rate of the vaccine coverage completely went down. And because as the government basically stopped active recommendation of the vaccine, wherein actually they call up the people, they send reminders, they send a voucher and ask you to go to the local clinic and get the vaccine. A similar thing happened in Kazakhstan as well. So there was a pilot introduction of the vaccine that happened in 2013, 2016. Again, there was some kind of like some of the side effects that are associated in timing, but not caused by the vaccine. But again, it led to negative sentiment in the communities, and then the vaccine did not get introduced nationwide around 6-7 years before, which is what was supposed to happen. And then in this case, in Kazakhstan, the government actually stopped giving the vaccine. So none of the adolescent girls can actually even get it, even out of pocket, even if they're willing to pay, they cannot get the vaccine. And some of them who wanted to get the vaccine actually had to go to another country, get the vaccine, and then come back. But in the recent past, Kazakhstan has moved to introduction of the vaccine. It started like recently, in less than 6 months before October of 2024. And then we also conducted some cost-effective analysis of the cost of Kazakhstan as well. And we found out the 2-dose vaccine was also cost-effective, but the 1-dose vaccine was also almost twice as cost-effective as the 2-dose vaccine. But because of the negative sentiment that was happened before, so the health ministry is very cautious and they want to introduce the vaccine as a 2-dose vaccine right now, even though from a cost-effective perspective, it's not as efficient as a 1-dose vaccine. They want all the social mobilization campaigns that happened even for 1 year before the reintroduction of the vaccine. They are being very cautious and going with the 2-dose vaccine right now. So what happens with the 1-dose and 2-dose is that one of the things is not only it's more cost effective, it's actually much more logistically easier to deliver as well. So globally, even with the current rates, for a 1-dose, for a 2-dose vaccine, current coverage is like around 20%. But if you go for a 1-dose vaccine, we can almost reach 30% even right now. And these kind of differences that we can see, the drop in coverage, when you go from a 1-dose schedule to a 2-dose schedule is seen across different regions as well. Although in the case of the European region, it's actually marginally much less difference compared to other regions. So some of the key messages is that countries that have a relatively higher cervical cancer burden and relatively higher need for HPV vaccination so far have had relatively lower coverage since the vaccine became available in 2006. That being said, at Gavi negotiated prices, HPV vaccine provides positive net health benefits or is highly cost effective in all Gavi supported countries. And with a single dose vaccination strategy, it's not only efficient, it's a pathway towards affordable access and also feasibility and improvement in logistics. And that being said, as we are seeing from examples in Finland, Denmark, also like Japan and Kazakhstan, it's not only availability of the vaccine, but the introduction should be supported through good social mobilization, effective communication, and also if there are any safety signals that are that are shown among the girls who receive the vaccine, should be rapidly investigated and also publicly disclosed, so that with good transparency and good communication, we don't lead to a drop in like vaccine confidence and negative sentiment of the population. So what we can see is that there are several factors that needs to come in. So one is, while we kind of understand the burden of cervical cancer, and then with the vaccine, this vaccine, especially the underlying vaccine technology, is a viral-like particles. So actually having any negative side effects from the vaccine from biologically is just not even feasible. Actually, it's one of the most safest underlying vaccine development platform that has been used. And also to understand whether it's cost effective and also whether it's equally distribution and feasible because they have infrastructure resources. All of this is basically in regards to the constraints from the supply perspective. But then we also have to look at from the demand perspective. And if there's not enough vaccine confidence or stakeholders acceptance, and that's what happened in the case of Japan, basically these two completely dropped out. The government backed out and also the community didn't want it. So which is why it led to lower coverage. And in the case of Kazakhstan, actually community didn't want it, but the government backed out of the program and until the recent introduction, which is again, they're doing it very cautiously. So we have these several different factors that have to align in order to actually make a vaccination program more successful, rather than just use of good. It's not just availability of resources, but also additional factors, including confidence and stakeholders' acceptance are also key in this process. So with respect to advising, how it happens is that even before a vaccine is actually developed, so we have this group, which is the Product Development Vaccine Advisory Committee, which actually prioritizes which pathogens for which we need to develop new vaccines. And then once those vaccines do get into close to phase 2, phase 3 trials, there are actually like vaccine impact modeling studies that are conducted. And those methods are actually, they go through a review process at the Immunization Vaccine Implementation Advisory Committee before they ever reach the SAGE, which is the Strategic Advice Group of Experts at WHO. And this is for global policies and strategies that they look into. And then when the vaccines do get kind of a WHO approval for to basically to recommend those vaccines, we have the Market Information for Access Advisory Group, which looks into account any kind of market information gaps and how that could be addressed with respect to if their demand is not met, what needs to be improved so that we can improve equity and access to these vaccines. And this is done at the basically at the global level, it's a strategic advice group of experts. At the regional level, we have a similar group as the Regional Immunization Technical Advisory Group. And at the national level, we have the National Immunization Technical Advisory Groups. And the NITAC in the context of UK is referred to as a Joint Committee for Vaccines and Immunization. And this is a group that considers the evidence with respect to effectiveness, safety, cost effectiveness, before they make a recommendation for inclusion of any vaccine in the NHS program, which is publicly funded program to provide vaccines, and also any healthcare service in the UK. And with regard to this, the evidence that is being presented, so the model-based projections that are done, so it's done by a unit that's kind of internal to the UK Health Security Agency, but it's done in partnership through something called NH, Health Protection Research Unit for Immunization, which is a kind of a joint group between UK Health Security Agency, London School of Hygiene and Tropical Medicine, and University of Cambridge. So this is kind of a group that is looked internally, which is basically trying to provide evidence for the government. But that being said, they also commission one group that's completely external of any partnership with the government, which is currently in the context is the University of Warwick, which has been commissioned to do these studies, which is an external group. And then also manufacturers can present their perspective as well. So we have these different groups that present: manufacturers, UK HSA group, internal group, which is in partnership with some of the universities. And then you have a group that's completely external, but is still commissioned by the government. So which is the university. So all these groups put together, and then they take the collective evidence, especially for modeling-based evidence. But not only modeling, all other aspects also goes into like the epidemiological perspective, from the clinical medicine perspective, before they approve any of those vaccines. And I'm part of this vaccine impact modeling consortium, wherein we provide estimates for Gavi-supported vaccines. And at the London School, we provide estimates for HPV and measles as well. And for each of the vaccines, there are at least two groups that provide those estimates. And then it's across the Gavi-supported portfolio. And in this case, the Secretariat, which is based at Imperial College London, and then the modeling groups that provide those estimates, which is at least two groups per pathogen. And then the health impact estimates are then sent to or shared with both, in this case, the Gavi and Gates Foundation, as to who are the funders of this. And especially it informs the Gavi investment portfolio as well. There's an intermediate group, intermediate step, actually these health impact estimates, the economic impact estimates will also get added to this before it's used for the investment decisions. And with regard to the current, so the group which has been there since 2016, and now it has been extended, the second version of this, until 2027 across the Gavi supported vaccines, but also trying to build an ecosystem that is transparent and also coordinated across different stakeholders as well. So the pathway to do this is currently, so we have the modelers, but then based on the disease-focused questions, and that is basically raised by policy makers. And then there's a kind of which is primarily raised within the relation with stakeholders and so forth. For each of those questions, a corresponding project working group is set up, so which includes modelers, but also stakeholders. And this is facilitated by the Secretariat as well. And then, since the modelers are now working on questions that are raised by the stakeholders, and then when the modelers do complete their analysis, they do present it to the stakeholders, or in a kind of a feedback loop process, thereby there's much more potential for actually uptake of those analytic results for decision making. So this is one of the way in which basically the model-based evidence is used for policy making. And currently, as part of the consortium, we have an affiliate scheme where we encourage early career researchers to join the network. We also have fellowship opportunities where researchers can visit any of the modeling groups of their choice for a period of time. And also we have short course capacity building programs as well. And also there are requests for proposals that if it's of interest, I encourage you to join as well. And this is the Secretariat members, and you're welcome to reach out to the Secretariat at this email, and this is the website. And that's all I have to say. I will stop here. Thank you very much.
Thank you so much, Kaja. This was a really great talk. Fantastic to hear about the a vaccine with the lookout to potentially eliminate a cancer, these huge inequity gaps that you raised, the Gavi Alliance, and also the VIA-MC project. Really great projects and interesting talk. I would encourage anyone who has any questions, please put them into the chat or raise your hand. You can raise your hand on the bottom of your screen. There's a little hand to ask a question. We'll have Kaja here for a little while before he needs to go to bed. I'm happy to kick off what people might be still thinking. So really fantastic work and many issues that you mentioned regarding safety signals that are, I guess, in a way also expected if you try to achieve large coverages. I'm wondering specifically on your on the Gavi initiative and the this alliance that negotiates prices. To what extent is modeling and health economics modeling used to inform those prices that are negotiated? Do you know? Do you have any insights into that?
Yeah, so Gavi does this negotiations on like a 5-year cycle. So the Gavi, like the 6.0, just the negotiation cycle actually finished. So it's going from 2026 to 2030. And Gavi looks at the whole portfolio of vaccines, not just, I mean, of course, each vaccine estimate goes into the analysis, but they look across the whole portfolio. And then, for example, like in the last cycle, like for example, they did renew HPV, measles, and so forth. And many of the other currently supported vaccines were renewed for continued funding. But that's again only for countries that still are eligible for Gavi support, because some of the countries have actually transitioned out of Gavi support as well. But that being said, there are newer vaccines that are entering into the for potential like investment case. For example, the dengue vaccine that's been looked into. On the other hand, for example, in the last cycle, they also looked at the chikungunya vaccine for introduction as well. But then the evidence base for chikungunya at this time, it was around 2 years before when this analysis was done for chikungunya. There was actually very limited evidence even on the disease burden for chikungunya. So we have a new chikungunya vaccine that got licensed in November of 2023, which currently has licensure from the US FDA, EMA, and also MHRA, and also like not MHRA, but Health Canada has also provided the licensure, but currently for a travel medicine market. But the vaccine development was funded by CEPI, not for a high-income setting, but mostly meant for settings where there's a need for it. But that means also that's where Gavi support could have been useful. but the evidence base was so limited on the health impact and also the economic burden. Gavi actually didn't include it or didn't make it into the investment strategy. So basically, the economic evidence is kind of the key part, but it's not the only part that goes into this. There's also feasibility that takes into account and the current financing mechanisms. But once the number of doses are determined, the way to incentivize manufacturers is they give at least a 3-year commitment. So once the prices are set, they can, because it takes a long time to produce a vaccine. Sometimes it can take around 9 months. So you need the kind of a streamlined bulk order of vaccines. And then that prices are locked for at least for 3 years. So that even if there's a new innovation that comes in, and the pricing may go down for a new product that comes in, still those companies are, they have the, what do you say, the prices are lower compared to what any single country could negotiate, but still it is sustainable for the manufacturers to continue producing the vaccines. Yeah.
Thanks. Yeah, a really interesting blend of health economics and game theory. Almost. Thank you so much. We have a question here from Rock in the chat. He's asking about the plots that you showed earlier about the per dose impact of the HPV vaccine and Africa leading. Could you just briefly explain again why Africa was so much higher than other countries? What was it? What does it rely on?
So one is in the case of HPV is that like the risk of HPV gets higher with HIV co-infection as well. So the rates of HIV are relatively higher in case of Africa. So that's another enhanced risk factor. So the overall risk of HPV infection and then also prognosis to cervical cancer is much higher in many of these countries. But also in combination with healthcare access, because in, for example, like more high resource settings with screening, you can actually detect pre-cancer lesions, and then you can give treatment at a very early stage, so it doesn't progress into full-blown cervical cancer. But that's not available in many of the countries, especially in Africa. So it's a combination of enhanced risk, but also lower healthcare access, relatively speaking, which leads to a higher burden of cervical cancer in Africa.
Thanks. Yeah, really, and thank you, Rock, for the question. We have another question here from Alina about how these cost effectiveness analyses are used in these negotiations. So are they sometimes used to convince policymakers to recommend a vaccine? So maybe you can speak to this also in the context of the project you shared at the end.
Yeah, for example, like in the context of the UK setting, for example, the Joint Committee for Vaccines and Immunization, if there's a new vaccine that comes into play, for example, if it costs more than £30,000 per healthy life year gained or per QALY gained, it will not get recommended by the Joint Committee for Vaccines and Immunization. And £30,000 is a really extreme threshold. It's normally around £10,000 or less. In fact, anything more than £10,000 per quality adjusted life year gained is very unlikely to actually make it through the Joint Committee for Vaccines and Immunization recommendation. So that's the threshold that's used in the UK. Each country has their own different willingness to pay threshold. But that being said, just because a vaccine is cost effective doesn't mean it will still get included as well. So there are other things that goes into this. For example, do we have what is the current underlying health burden that we can actually reduce? And also how feasible is it to actually provide the vaccine? Do we have infrastructure in place? And also, is the community willing to take one more vaccine? So all of that goes into this before it actually will make it into the into actual policy. Yeah. But cost effectiveness evidence is key, but it's not the only piece of evidence that goes into decision making.
Yeah, I think that's an important point to make as well. Also related to this, I was wondering, so you're advising for the UK context, obviously, but on particularly thinking about the different countries in Africa, and you showed this very interesting results that especially there's a high cost effectiveness compared to other interventions. Do you have any experience or any advice, and have worked on projects that bring your results to policymakers there, especially where maybe health economics might not be something that can be done locally? have you done this, and in what form do you provide those results? Because again, everything is very context specific, I imagine. Can you talk to that? Thank you.
Yeah. For example, like the analysis that we presented for Kenya was actually led by colleagues at the Kenya Health Ministry. And both the departments were involved, like the vaccine department as well as the cancer department as well. So both the health, the departments, and it was led by the colleagues in Kenya as well. And then it also, I actually only showed the modeling part. Actually, most of this work will also work with a stakeholder group, which is a domestic stakeholder group. So you'll have key folks involved from the health ministry, but also from other programs. For example, the HPV vaccine program is delivered through schools. So you'll have the representatives from the education department, also part of the stakeholder group. And then it's presented to them, and then basically the decisions are made in a kind of even when the questions are framed, it's in discussion with the stakeholders, and then it's basically, and it's led domestically, and then it's presented to them. And especially if those questions are raised by the local stakeholders, is much more, how do I say, pragmatic for actually acceptance of the analysis or use for decision making, rather than something that's completely coming from outside. Yeah.
Yeah, it makes sense. It seems almost impossible to do those costings as an outsider. It's very context specific, I imagine. Okay, looking into the chat, you've been answering all questions. Is there anyone else who wants to ask Kaja a question? It has been very clear, it seems, and it has been a real pleasure to have you. I think, yeah, let me just repeat a big thank you to everyone who joined today, and thank you for the questions and the discussion, and a very big thank you, Kaja, for joining us with a very interesting talk again, and thank you for joining all the way from Japan.
Yeah. But thank you for having me, and if there are any opportunities to work together, feel free to reach out to any of the colleagues in the Vaccine Impact Model Consortium. We are happy to partner.
Fantastic. Great to hear. Thanks again, and thanks everyone.